Can you say that again? Because that's important. Sorry.
I've been in research since I finished my residency in '82. I run an fMRI lab. My son was diagnosed with MS, and that's how I got involved here. His experience is part of the story, so I want to tell you a little bit about it. In May, he had double vision and a right facial palsy. He was hospitalized for 3 days, saw 3 neurologists, had the most dramatic spinal tap I had ever seen, all sorts of MR. He was given a diagnosis ADEM. Well, when I finished my residency in '82, that didn't exist, so I left thinking, wow, they've made a lot of progress in MS since I was involved. And then December, 5 months later, he had an ascending numbness, was reevaluated, and was diagnosed with MS. So I decided it was time to catch up. So I went to the library in PubMed. My wife went to the internet, to Google. And I want to just summarize. I'm just going to read these 2 quotes word for word, because it was really kind of shocking to me after 30 years to discover that this is the state of affairs. So this is the main textbook for MS by Herndon. The possibility of it being a primary infectious process with or without an associated autoimmune reaction has not been entirely ruled out, despite repeated failure to identify a causative agent. Over the last 4 decades, at least 14 different viruses have been isolated from the brains of MS patients, yet none has been shown to be etiologically related. Cook listed 22 agents suspected of being related to MS, for which substantial evidence of a causative role has thus far not appeared. Well, that was shocking. Neurologists have been telling patients all these years it's a cocktail of viruses, there's a number of viruses. But when you actually look at the papers, and review papers in particular, that's not what the articles have said. The same thing is true on the autoimmune theory. So I'm going to read you this entire quote too. These significant data seem to have been ignored by some who are willing to defend the theory that MS is an autoimmune disease mediated by immunopathological mechanisms, despite overwhelming evidence to the contrary. Studies of these agents show that the inability to go beyond the 33% line raised the possibility the entire observed benefit is only a placebo effect. It could be argued that over the years, the autoimmune hypotheses have been harmful to a considerable number of patients. Basic studies on speculative immunological mechanisms are continually shown to be unrewarded. It is clear that modern research should move away from the autoimmune theory. So this is where I got to in late December, when my wife started talking about something else. The CCSVI. So I run an fMRI lab. I want to explain a little bit what fMRI is, because it turned out it has an application here, and that's what I'm talking about today. So fMRI is MRI, only instead of one snapshot, you collect snapshots every 2 seconds, and during that 2 seconds, cognitive area, you activate the cortex with some kind of cognitive task. The cluster, the region of interest of neurons that are activated by that task, call in a surge of blood. That's called a hemodynamic response. That surge of blood is oxygenated hemoglobin, then deoxygenated hemoglobin. Deoxygenated hemoglobin is paramagnetic, so the MR scanner picks up that change going from the oxygenated to the deoxygenated, and you get a little bit of release. So this is what a typical fMRI looks like. I particularly like this one because the kind of research that I was doing before my son got MS was in meditation. I was very interested in meditation, and so most fMRI studies you will see are group studies because the brain's very noisy, the brain's never quiet. So this is a single subject, so it's an unusual slide because you hardly ever see the brain quiet, but that's kind of the fun of studying meditation. You're actually really studying is how do you make the brain really quiet. That's essentially what meditation is. So what you see here is deactivation in the rostrolateral prefrontal cortex, which is the tension area. So you see tension reducing, and then interestingly, you see activation in the insula. the insula is the part of the brain that receives visceral information from the body. It's thought to be the area that's involved in empathy and compassion. So this is kind of a nice slide about meditation. When you're meditating, the whole brain goes quiet, your attention area deactivates, and maybe even you have sort of a positive empathic experience while you're doing that. So I reasoned that if this CCSVI theory is true, then possibly fMRI can be used to look at not the flow in the neck, but the actual flow in the cortex, in the areas that are being activated. So this is what's called the Buxton model, the balloon model of how the hemodynamic response works. Buxton is at UCSD, where I trained with him. And basically, you get a characteristic response to an activation where you have a surge of blood coming in as it's being called in by the activation of the neurons that are going to whatever the task is, a visual task, a motor task, a cognitive executive task. There's a surge of blood that comes in, and then during the length of the task, you have a plateau, and then you have a dropping back, but rather than dropping back to baseline, it drops back below baseline, and this is called the venous undershoot. So this is a characteristic that's known about fMRI. In general, it's looked at as a standard function, so it's not looked at specifically, so no one has looked at this in any diseases of any neurodegenerative diseases, including MS. And the idea that Buxton came up with is that this venous undershoot is caused by a balloon effect. The blood comes in, and then it dilates the capacitance vessels, the capillaries, and the venules are a little bit dilated in a balloon effect, and then the balloon dilates, the cognitive cortical area balloons a little bit, and then it goes back to normal. And so that ballooning is what's causing the undershoot. So I reasoned that if in CCSVI there's a problem with drainage, then one ought to see an abnormal venous undershoot. So I came up with a task, tell-time task, where what the subject does is here's the time of day, 2:20, sees two clocks. One's the right time and one's the wrong time. And with two button boxes, the instruction is to choose the wrong time. So you have an auditory task, so you can look at the auditory cortex. You have a visual task, so you can look at the visual cortex. You have a motor task, so you can look at the precentral gyrus. And you have an executive task, you have to inhibit the natural desire to choose the correct clock, instead choose the wrong clock. It's a variation on a pretty common cognitive task called the scoop effect. And so this is the task that we started showing to MS patients, and now we have about 30 of them. I'm just going to give you one example. This is an MS patient, this is a control patient. This is a pretty typical pattern that you saw on that earlier slide. You have the surge of blood, plateau, returning to normal, and a venous undershoot. And this is the MS patient, where you have a steeper and higher going to the top, no plateau. You hardly see any plateau at all. It's coming straight down. And then this is actually twice as deep. And this is a fairly early study. In fact, this comes right back up to normal. In the MS patients, it comes way back out. In fact, you have to go about 60 seconds out to see the other end of this. So this is patients versus normals. This is now what the actual scans look like before and after angioplasty. So you don't really learn too much from this, but this is before and after angioplasty. This is literally the day after. This is before the angioplasty. This is the day after angioplasty. And basically, this is 4 different regions, prefrontal, so this is the executive function area. Precentral, this is the motor task area. Parietal and visual. In all 4 of these areas, you see an abnormal venous undershoot. Right? So this is actually looking at where you care about. Right? You don't really care about obstructions in the jugular veins. You care about delay in the cerebral cortex where we live. And so this is actually an objective look at poor venous drainage in the cortex of 4 different areas.
I'm sorry, quick question. Did you also do a normal control patient, doing it twice to
You know,
factor in
I'm just
the?
not gonna do sham angioplasties in people. I really
No,
just
not doing
have to have-
angioplasties. No, not doing angioplasties, but doing the same task again, to see how much of that might factor in repeating the task.
No, I haven't. So,
Was that a jugular angioplasty that was done in that patient?
that patient was 2 jugulars and 1 abscess.
All right.
So, I don't know where this would go, but where I'm hoping this could go is a non-invasive way. We can actually look at what we want to look at. The hope would be, and now we've collected data in about 30 patients, and I hope we'll be publishing this maybe by February or March of next year. It would be nice to be able to say, this person has venous delay or doesn't. That will be helpful information as to deciding what to do about a questionable. If somebody has no reflux and maybe just goes stagnant for a second, maybe this will help us make that call. Also, when it comes down to the issue of restenosis, it might help us solve that question too. So this is just the beginning of this research. But I want to just bring up another subject. I'm not going to read this one or mention names, but neurologists calling this a hoax, calling it
Modern day
quackery, source insanity, refute metabolite science. This is not what neurologists are doing. When I was in training, we were the smartest guys. It's really bothering me that my community is being so negative about it. At the very least, is an intriguing idea. So, in summary, as far as I can see, standard neurological thinking has just not been proven. The viral theories and the autoimmune theories have not been proven. The drugs, my son takes ribs every 3 days. He has a flu-like syndrome, vomits sometimes, nasty drugs, barely proven to be efficacious. CCSVI is the most exciting thing happening in MS, and I think that neurology ought to be embracing that. Where we got to go is how many of the so I did the Pinky protocol I went to the Hamilton meeting, spent time with Mark Hakey, learned his protocol. We have a Siemens 3T machine, so we can do the full SWI. So we follow Mark's protocol exactly. We get very upset if he sends us a note saying we didn't do it quite right, we got to do aliasing on something. We do not do Doppler, but I do think that I send the data to Hakey, so it's not, I don't tell him what the diagnosis is. I try to send him normals as well as abnormals. So I trust that I'm getting the most sensitive test I can. But of course, the real question is, what's going to be the relationship between Doppler, MR venography, and catheter? So that's the first thing we're going to start seeing. I think we're going to want a 10 or 15% false positive rate. We want that with appendicitis, right? We don't want to be having every surgery we do come back with an inflammation. We want to have some. So far, that has not happened. We've now done about 5 or 6 cases. I do have an IRB, by the way. We're going to have to see what that number is. What % are not improving? So far, we've had 1 person who does not seem to be any better. Most of the patients do seem to say that their feet get warmer, fatigue goes away, the headache goes away, but there are certainly those who have had no change in their ataxia or their walking difficulty or their you hear some absolutely amazing stories out there. I see it. There's probably been about 1,500 people who've had this procedure, different places around the world. I mean, have to have some kind of a registry, some kind of a way to put all this data together and look at it. We don't know the answer to this. What's going to be the best way to deal with restenosis? Fortunately, so far, it looks as if it's pretty clear to the patients. They know what got better when they had the angioplasty, and they know when that symptom came back again. So I haven't found that to be confusing, but at some point it will be confusing. At some point we'll have to make the decisions about that. And then isn't it likely that all of stenoses are not going to be only in the easy places, the bottom of the jugular? isn't it possible we're going to see narrowing in the straight sinus of this vena galen or thalamus striates? This could get a lot more complicated, not just a lot more easy. After all, the pathology we care about is in the cortical vein, white matter and cortical venions. That's the pathology we care about. And so it may not be that that's always going to be pathology that far distant, because we're going to have to worry about it farther up. And so maybe there'll have to be other kinds of treatments, other kinds of endothelial-oriented treatments. Now, I want to take a moment to finish this with what the theory is. So, Paulo's theory, as I understand it, is that backflow is causing is damaging the endothelium, allowing RBCs and iron to break through the endothelium and to then incite an autoimmune phenomenon. Well, we already know there is no autoimmune attack on myelin directly. So why are the white cells, why are the cells going in and gobbling up iron? So even the new theory doesn't really quite explain that. So at least I entertain the possibility that the real problem is stagnation in the brain. It's not really just a flow problem, but that stagnation, poor drainage of the swamp, is weakening the oligodendrocytes. The oligodendrocytes are the cells that make myelin. So another way of looking at this is a toxic environment from a poor draining system is allowing toxins to develop around the oligodendrocytes. The oligodendrocytes, maybe nitrogen oxide, maybe one of the glutamate or one of the other transmitters, and that is allowing the myelin to fall apart. The myelin falling apart is then scavenged by the white cells. It's not that the white cells are attacking them, but that they're cleaning up the mess from the oligodendrocytes. So tons that have to get done. This is just the third meeting like this. It's going to get more and more complicated, but it ought to be